Okay, so what we're going to talk about is how do we initiate our vent on our patients here, and what is involved in settings that don't have specific orders attached to them. So, in order to put a vent on a patient, there's minimal ordered settings that have to be done by the physician. One being you have to have a peak airway pressure or a volume order, a PEEP order, a rate order, and a FiO2 or a keep stats greater order in order to initiate the mode on a patient. But in different modes they have also settings that affect patients' ventilatory status that don't have to be specifically ordered. Now they can be ordered anytime a physician wants to dictate that specific setting needs to be something, and it doesn't fit what our practice or our policy or guidelines are for setting it. But what we're going to do is go through our most common setup is where the physician only orders those needed orders and everything else is left up to our algorithm and guidelines and policies to set them. So this patient currently, we intubated just now, and the doctor's order was to put him on 20/5 with a rate of 20, keep stats greater than 92, and pressure support of 10. So we would initially go in and we would have to set those orders as he had ordered to, that he had told you. So we have here on the servo 20/5 with a rate of 20. Now we have the O2 set at 90 just because that's what this particular situation is calling for, because he wanted sat greater than 92. And we have all these other settings still that need to be set without an order. We have the pressure support that has an order tied to it and it's set at 10. The I time, the rise time, the trigger, and the percent cycle. These are all things that greatly affect the ventilatory status that need to be set. So the first thing we're going to do is we're going to start the vent with those ordered settings plugged in. We're going to look at our patient. We're going to set this I time to get a 1:3 IU ratio with that ordered set, just as a guess. In there, and then we're going to immediately look at our waveforms to set the rest to manage the rest of those settings, right? So we're going to first, I'm going to look at my waveform and I'm going to immediately notice that I have a huge leak right here in front of me on the volume scaler. You see it goes up and it doesn't come all the way back to 0 on the expiratory phase, so I know I have a leak. So I immediately have to figure out, is it a correctable leak or is it a leak the patient is going to have? So on this situation, I look at the kid, I come over here and I notice he had a cuff tube. We intubated him with a cuff tube, so I know there shouldn't be a leak from that area. So I'm going to come in and I'm going to listen. I hear a leak over the trachea, so that means I'm going to inflate my cuff until that goes away. That would be our minimal occlusion policy. And then I would come back and I would look at my vent and see, is that leak gone? Okay, so the leak is mostly gone. That's there because it's a mannequin. But the leak is mostly gone, so now I can progress further. Now, if the leak doesn't go away and it remains like that, I need a physician guidance on setting anything, because I have this huge leak and that affects how we set the other settings. But we'll get to that. So my leak is fixed. So now the next step is to look at my I time. I need to set my I time to where my waveform on my flow scaler in the middle here gets to 0 flow. And when we talk about 0 flow, that term is always referred to in the inspiratory cycle here. It's never referred to as during the expiratory phase. So some people get inspiratory 0 flow confused with, is the expiratory flow reaching 0 on expiration? That's not what we use as our terminology here. If we're asking, are we getting to 0 flow, they're referring to the inspiratory phase. Is the inspiratory flow coming to 0 on inspiration? If they're looking for expiratory flow coming back to 0, they're going to refer that to, is there any air trapping or auto PEEP? Okay, so the first setting we change after we enter our ordered settings, or the first settings we have a policy to adjust on our own, is the I time. So based on the patient's size, you have a set time frame you could work within. So a toddler, you can work within 0.6 or 0.4 and 1 second, for instance, right? So 1 second. But you have to be able to get to zero flow on the waveform within that time frame. So the first thing I'm going to do is I'm going to come in here and I'm going to start right off the bat, start setting my I time breath by breath so that this flow gets, until this flow gets to zero, right? So I know, because I know this mannequin that I have needs to have a 0.95 second I time in order to get to zero flow in these settings. So I'm getting to there finally, right? So now at 0.95, maybe even 1 second, which kind of caps out our leeway we have with this 1-year-old, I get to zero flow on my waveform. This is vital because we're really good at looking at how much volume per kilo has moved on the patient and targeting that. Usually we target it within the 6 to 8 per kilo range. If you don't fix the I time from the get-go, you're going to have lower volumes because of the I time being so short and the breath being cut off too soon, and you won't use the entire lung available to you. You'll basically be cramming whatever per kilo tidal volume you have into less than all of the available lung, and mostly it'll be the most least compliant lung part of the lung that actually doesn't get to see any of the peak airway pressure, because that's the last part of the I time. That's the part of the lung that the I time reaches at the end. So we want this to be minimally zero flow. Now let's say, for instance, this is a 1-year-old, and for whatever reason, we have to go out to 1.2 seconds to get to zero flow on our waveform. What do we have to do as therapists? Well, we have to not do that. We have to set it at 1, and we have to notify the physician and call them to the bedside, because we need to figure out, need to have some direction, right? There's something that's not quite right, because a 1-year-old shouldn't, in most cases, need longer than a 1 second I time to get to zero flow. And if they do, there could be other things happening. He could have a T fistula. He could have been weighed wrong. We could have the wrong weight. And thus we're targeting, bigger volumes than we should. There's a lot of things that could affect that we need physician oversight to come help us decide how we're going to handle this situation, right? But without that, we are going to set zero flow. Now, we have to get to zero flow. Again, we have to get to zero flow. If we can't get to zero flow, we have to have a doctor tell us what to set that time frame and order it. Okay, so we get to zero flow on this mannequin, and at 1 second, so we're good there. The next thing we're going to do is the rise. Well, our policy guidelines say our goal for our rise setting is to get a decelerating waveform on the patient. So if I set my rise time too fast, you see what will happen on the waveform. You'll get a very sharp spike on the beginning flow. The rise time controls how fast the vent is attempting to get from its PEEP to its peak airway pressure. How fast are you going to get there? Are you going to flush the system with as much of flow as you can to get there as fast as you can, which represents a 0.000 second on the servo? Or are you going to take your kind of more leisurely time reaching that peak? In this setting, the leisurely time would cause least amount of turbulence in the flow. The faster the flow gets crammed in there, the more turbulence and wasted pressure versus volume occurs. So if I go to 0.2 and make it really slow, now I have a lower peak inspiratory flow, so I'm getting there more sloped. So I'm not quite in a sudden hurry to get to my peak pressure. You can see it slopes up on the pressure curve. However, the downside to doing this is if the patient should start breathing spontaneously and taking breaths, they're going to want a faster flow rate at the beginning of their breath, and they'll start dipping this pressure curve on it. So what we target always is the nice decelerating waveform, not too slow. Too slow is rounded at the peak. See how it's rounded off? So I don't want it rounded. I want a nice, is close to, that's too fast, so I'm going to slow it back down and get to a nice area where it's as close to a decelerating waveform as I can get, and we're going to do that on every single patient, of course, unless it's ordered otherwise. So I'll march this out. Okay, we got some circuit bounce in there. Okay, that's probably where I would stop on this kit. The next thing we have to set is our trigger or trigger of the vent. Okay, so our policy says that unless otherwise ordered, we're going to set that trigger to be as sensitive as possible without auto-triggering occurring. Now, auto-triggering occurs when the ventilator perceives flow dips or flow decreases and thinks that it's the patient actually trying to initiate a breath, and thus gives them a pressure support breath or an additional breath. And that could occur from multiple things. The most common here is if you have an uncuffed tube or a leak, some of the flow won't return to the expiratory cassette, and that's where the servo is looking at if the flow is missing and thus giving another breath, right? It'll escape out the leak into the room and it won't return. The bias flow won't return to the expiratory cassette in the percentage it needs to be, and the vent will think this patient is taking that flow and then give them a breath. So what we want to do is make it as sensitive as possible without that occurring. The next common thing that occurs is a patient with a hyperdynamic pulse, and what that is basically when the blood pressure goes from systolic to diastolic, the aorta can stretch, and it stretches as it reaches its systolic state, and it's only supposed to move into a certain area. Well, if for some reason it's stretching too far, the blood pressure might be within normal range, but the aorta might stretch too far. The vascular bed down there might stretch too far, and when it does, it hits the diaphragm, and when it hits the diaphragm, every beat of the heart causes the aorta to kind of bump the diaphragm, and then when the diaphragm gets bumped, it moves flow through the vent circuit. And if it's enough flow through the vent circuit with your combination of how sensitive you're going to make, the vent will start picking up those as breaths, as spontaneous efforts, and start giving the patient breaths. Now, some key ways to identify this is that if your patient is in respiratory alkalosis on his gas, but he is breathing over your set rate, that would be a possibility to look into, does this kid have a hyperdynamic pulse, and is it auto-triggering? But nevertheless, the case, whether it's a leak or whether it's that, or if it's something else, we're going to attempt to try to figure that out, and we're going to make this as sensitive as possible without that occurring. Now, if we get the flow trigger down to 1 on the flow trigger side, and it's still occurring, then we are able to move into pressure triggering to get rid of it. And we can continue to move into pressure triggering, again, by policy, as sensitive as possible without auto triggering occurring. So if I have to get into, a -3 of a pressure trigger for the vent not to auto trigger, then that is what we do, right? If we can set it to 5 without that auto triggering occurring, that's what we do. As sensitive as possible without auto triggering occurring. Now, the last thing we have here on this mode I'm showing you is the percent cycle. Now, what the percent cycle does is it cycles the pressure support breath only, and it cycles it based on a flow termination. So what we're doing is we're setting this at 1% on all our patients from the get-go. And what we're doing here is basically mimicking our zero flow policy on the I time that we just talked about. How we set our I time to get to zero flow on the waveform. Well, we want our pressure support breaths to give that same benefit, to fill the lung as much as it use all the lung during the pressure support breath, so we get a lung that's equally expanded, and we identify that because the vent doesn't need any more positive flow and inspiration. Well, that's what occurs when you have a percent cycle at 1. The percent cycle, basically on a pressure support breath, each time it cycles in, it measures what is the peak inspiratory flow that occurred on that breath, which would be like right here at the top of this, and then it waits until that flow need slows down to 1% of that peak. So if that pressure support breath had a 100 liters per minute peak inspiratory flow, this 1 would mean that that breath would have the inspiratory flow need from the servo would have to slow down to 1 liter per minute. And when that occurs, the patient is then able to exhale, and by the vent then cycling to expiration. We want this to be at 1%, at as much as we possibly can, right? Well, if 1% is the answer for everything, why is it even settable, right? Why doesn't the vent just default at 1%? Well, the reason it doesn't default at 1% is because leaks cause a problem. So what we're gonna do is, we have this patient that's on has a pressure support and he has a leak. Let's say he has an uncuffed tube or an uncuffed trach or whatever have you, he has a known leak. And with that leak, he had on his pressure support breast, you see this waveform. The flow goes in, the flow decelerates, and then at this point, the flow now stays constant at, let's say, 50 liters a minute. So if 100 liters went in, it slows down as the lung expands. And then at about this point, you have a constant speed from the vent at 50 liters per minute of flow. And the reason this is occurring is because the patient has a leak, the vent is required to like push a certain amount of flow through that leak in order to maintain the pressure, right? Well, you have the inspiratory cycle set at 1, so it's waiting for this flow to slow down to here, right? Well, it's never going to slow down because if it does, the pressure it's targeting would drop. So it has to keep this flow speed up, and thus the inspiratory time becomes this long. Well, we don't want that to happen, right? Because that means at some point the patient is going to exhale on his own, and he'll start pushing through this, which is still up at your high pressure support breath, and essentially he'll be exhaling through a high PEEP. Okay, so what we want to do is we want to identify this waveform is occurring, and the first thing we want to do is talk to the physician about fixing this leak. So if this leak is fixable, have it by getting a bigger tube or putting a cuff trach in, then that's really what we want to do in the ICU. We want to fix this. We don't want this occurring if we can get around it. Now, if the physician can't fix the leak for whatever reason, then we're stuck to not having this elongated I time. So then we would adjust our inspiratory cycle up until the point of this straight line occurs. So at this point, which looks like 50%, so if you look at this is the peak flow, it falls about here, and at 50% of the peak flow is where this leak problem happens. You would set your inspiratory cycle time to 50% or maybe 51. And then when you do that, the vent will wait for it to decelerate to 50% of its peak and then exhale. And it will now force this I time into exhaling before that leak process happens. And that is how we would set our percent cycle. Now, all these settings are able to be ordered by the physician. So anything out of whack, anything that doesn't make any sense, obviously kicks to the physician and requires an order, right? So if it needs an order, it just means we need to have a discussion. It means that there's some weird stuff going on and we really need to have a team discussion of how to address this. Okay, so that's our basic platform on how to set settings when you initiate a vent here. And this is pretty much across the board in all units. Okay, thank you.